So after the beast of cancer, we come to the beauty of the eye, and we'll have a beast present it. We'll be talking on lower lid blepharoplasty. So, well, technically not a lump and a bump of the eyelid, but when patients do come with requesting for a lower lid blepharoplasty, it's often because they have very, very localized swelling, or what they call under eyelid bags, or excessive hooding of the skin on the upper eyelid. So on my talk, I'm focusing only on lower lid blepharoplasty. And these are the 5 subheadings that I'll be talking about. Basically, assessment of a patient. What do we look for? How do we advise what type of blepharoplasty is needed? What complications are possible? And now, what adjunct procedures can we do along with a blepharoplasty? So the first is to assess the patient. So there are different things that a patient can present with when they come for a blepharoplasty consult. So the aim is to understand who is a good candidate and who is not a good candidate. And if you are a candidate for a blepharoplasty, what is the route for surgery and what surgery would you do? So patients typically have lower lid fat prolapse. This is essentially the orbital. There are 3 fat pads in the lower lid: the medial, the middle, and the lateral. The medial is a continuation of the intraconal orbital fat. The middle and the lateral are separate, isolated fat pads. They can even have malar mounds, which are fluid bags on the cheek, which often get mistaken for lower lid fat prolapse. And in all patients who present, especially with a subacute history of eyelid swelling, we need to rule out thyroid eye disease. So this is a patient who's coming with a lower lid fat prolapse, 28 or 30 years old. How do we know this is fat and not, fluid bags or anything else? A good idea is to have them look up. When they look up, the septum and the inferior rectus of the lower lid relaxes. In the lower lid relaxes, so the fat bulges out more prominently. The appearance of fat bags worsens on up gaze. And when you ask the patient to look down, the inferior rectus tightens, the septum and the fat retract, and the appearance improves on down gaze. So this is a patient whom I just need to tuck that fat under the subperiosteal pocket or even excise it, and the patient will have a smooth lid cheek junction. Now compare that to an elderly gentleman who again is coming to you with the similar complaints. I have lower lid fat bags. Ask the patient to look up, it becomes more prominent. Ask the patient to look down, the fat pads have disappeared, but you can see there is still some excess skin. So this is a patient in whom I'd want to do a transcutaneous blepharoplasty, tighten the skin, and also look at the inferior scleral show in this patient. You can see that there is about a couple of millimeters of sclera that you can see on the lower lid. So you'd want to also tighten the canthus there, lift the eyelid, maybe a lateral tarsal strip. So this tells you a good idea of how to do. Now these are malar mounds. These are patients whom you do not want to do a blepharoplasty in. These are fluid bags on the cheek. The best way to treat them is to refer them to a competitor, because there is no effective treatment for malar mounds. Do not miss ptosis. Now this patient has excessive skin hooding on the upper eyelid, but don't miss the right eye ptosis. You'll do a bleph, you'd end up not correcting the ptosis. The patient is not going to be happy. So especially in these patients with fluid bags on their cheeks, you want to rule out thyroid eye disease before jumping in for surgery. So a lot of young patients come to us seeking for a blepharoplasty consult, and there are some patients who fit into a case where I'd offer them a lower lid filler, and some patients whom I'll do a blepharoplasty. So there is a hills and valley concept. Now if you look at the patient on the left, there is a very prominent lower lid fat prolapse that extends. You can see that there is the medial fat bag is also prolapsed, the middle and possibly the lateral. Again, the fat prolapse is all over. Whereas here, the patient has only a medial fat bag prolapse. So, and also the prolapse is very gentle. It's not too prominent. Can I mask this hollow with filler? Yes, I can, because it doesn't go past the mid-pupillary line. So that is a rough guideline that I use. That's what I thought because of the crepey skin, but if you see the post-op, again, make the patient look up, the fat bags become very prominent. It's a telltale sign that these are fat prolapse bags. But if you do so this is a patient who had a transconjunctival blepharoplasty. The medial and the middle fat pads were tucked under the periosteum fat transposition, And the aim of blepharoplasty always is to have a smooth lid cheek junction, but the patient on the left received a filler injection, and the lid cheek junction could be smoothened out with a filler. She is 23 years. I don't want her to undergo a blepharoplasty now at this stage. So based on the prominence of the fat pad and also the depth of the valley, whether you can fill it with filler is when I choose this is a patient for filler, this is a patient for fat conjunctival blepharoplasty. I won't go into the surgical video in depth. I'll quickly just show the route. So inferior fornical or transconjunctival, give a little bit of local anesthesia, 4 mm under the tarsal border is where the incision is made. I prefer making my incision with a radiofrequency cautery. In your initial cases, it's good to make a complete linear incision and not localized incisions. This is a post-septal approach. You open the conjunctiva and the retractors, and you don't even need to go up to the retractors. You'll immediately see the fat pads pop up. There's something known as a globe retraction, and you depress the globe and the fat prolapses out. The fat needs to be injected a little bit with anesthesia, gently cut out, or you can use your cautery to cut it. Don't debulk it completely, just excise enough so that the fat bag's prominence reduces. You do not want to excise too much so that you create a skeletal or a hollowing look. In patients who need a transposition, you just need to extend the incision, visualize the inferior rim of the orbit, create a periosteal pocket, and push the fat bags underneath that. These are patients who've had transconjunctival blepharoplasty. They can be as prominent as this or as subtle as this, but the effect remains the same without a scar. Again, a young patient, he also underwent. So in this patient, all I want to do is trim out the fat a little. I don't even need to transpose it. Little fat excision is adequate. But in this patient, I would do a transposition because the fat prolapse is pretty prominent and also he's a little older. So here the fat, the middle and the medial fat bags are identified, taken with a Prolene suture, and a subperiosteal pocket is made under the skin and tied there so that it volumizes the cheek and smoothens the lid cheek junction so that the patient has a very clear, smooth transition with no bumps or humps. Is this the only way? No. A lot of patients also need transcutaneous blepharoplasty, and in transcutaneous we excise a little bit of skin. But how much skin needs to be excised, that is the most important part. Otherwise, it's technically a simple surgery. So I'll quickly run through that video, focusing on the part of how much skin needs to be excised. So what we need to do is make a subciliary incision. Before that, we mark how much skin is to be needed. So this is called the pinch test, where we pinch a little bit of skin, and the minimum amount of skin that you can pinch without the eyelid moving is position. Now, if I pinch this much, look at the eyelid coming down. This is going to cause ectropion. This much skin, the eyelid position doesn't change. So the minimum amount of skin that you can pinch and lift without the eyelid margin coming below on the conjunctiva, on the cornea, is the amount of skin that you need to excise. So laterally it's a little more and medially it thins out. In these cases, I take traction sutures to pull and make the lid taut. For skin incisions on the lower lid, there is no fold to hide it, so I make incisions with cold steel 11 number blade rather than radiofrequency cautery. Excise only the skin, try to save the orbicularis if you can. And once you've excised this is where you open up the orbital septum and look at the fat pads. Now you'd be able to identify the fat pads very easily here. You can differentiate between the fat pads. That's the medial, that's the middle, that's the lateral, and between the medial and the middle you will see a flesh band of pink structure called the inferior oblique. If you see it, run away from it, otherwise the patient will have possibly diplopia if you damage it. Now in this case we are excising the fat because this is a patient who had very, very prominent fat bags, and post-operatively you can see that the improvement is drastic. More importantly, a subciliary incision does not need to leave behind a scar. We can combine lower lid transcutaneous with an upper lid blepharoplasty also, which literally knocks off 15 years off the patient's face. This is transcutaneous. Things that we need to be aware of are complications. If you use cautery aggressively on the skin, in spite of a blepharoplasty, the patient looks far worse than what he probably looked before surgery. So these are kinds of scars that we need to avoid. Pigmented preseptal skin scars are very difficult to treat, which is why choose blade over radiofrequency and close meticulously orbicularis and skin in layers. Try not to excise too much skin so that you don't see lid retraction, but if you do, immediately start using 5-fluorouracil injections or triamcinolone injections to prevent the scarring, and do not delay corrective surgery, because if you delay corrective surgery, you're compromising on functional outcomes. You don't want to sit on a patient with lid retraction but have the patient suffer the side effects of lag of thalamus and exposure. So if you've made a mistake, go in and correct it. And again, fat transposition. So this is a case who's ideal for fat transposition. You can see that the cheek is very hollow. The level of amount of fat that is prolapsed is lot. You want to push it down. So I just put this case to show that how a case for fat transposition really presents. Adjunct procedures, you can add CO2 laser, speak to a dermatologist and have them do that. It takes care of pigmentation and also rejuvenates the skin. Now, this was a patient whom we did a fat excision. She just wanted the small medial bulges to be corrected. After surgery, she was happy. She had these hills and valleys. But then she came and said, it looks nice, but now my eye looks hollow. So it was, chicken and egg going there behind that, causing hollowing, fullness, taking away the fullness, leading to hollowing. So we then added a little bit of filler, and at the end, both the surgeon and the patient are happy. The aim of a blepharoplasty is to remove the prominence of the lower lid fat pads and create a smooth lid cheek junction. So to summarize, a thorough assessment is needed. A biggest red flag is active thyroid eye disease or a lymphoma. Like Feroz said, I would have probably gone ahead and done a blepharoplasty, but you need to have your thinking cap on. Counseling the patients and giving them realistic expectations. If patient comes and tells you, I want almond eyes like Katrina Kaif or Deepika Padukone, please stay away from these patients. At the end of the day, it has to be a customized management. One size of shoe doesn't fit everybody. What is needed in that patient should be offered to that patient, whether it's transconjunctival versus transcutaneous, and always adjuvant procedures like fillers, Botox, or lid lasers can be offered. So early recognition and management of complications is important to avoid functional issues that patients can develop. Thank you for your time, and thank you for the invitation, Dr. Soumya.
Thank you, Dr. Akshay, for that excellent tutorial. It's always a pleasure